have a hematologist friend of mine, and we were chatting, and he mentioned that unfortunately it is the obstetrician who can prevent thalassemia. So I was very thrilled to hear that I can prevent some particular disorder, but then I asked him what's so unfortunate about it. And he told me that the obstetrician hardly ever sees a child suffering from thalassemia, because thalassemia major child will present at an age of around 1 year or so, and by that time the patients never come back to the obstetrician.
First case situation is where the parents have had repeated stillbirths, that is, they have lost baby at the time of delivery. Now this could be because of both the patients are alpha thalassemia carriers and the baby is affected, that is alpha thalassemia majors, or they develop something called as hydrophitalis. The second case scenario is where I talked about beta thalassemia major. If one of the genes is abnormal, but because the other partner gene is normal, so they don't have any problems. But when a baby gets both abnormal genes, he can have beta thalassemia major. Now what happens is he is not able to produce enough hemoglobin. So within first few months, his hemoglobin drops, and unless it is supported by blood transfusion, the baby will not survive.
One of the common clinical situations that we face is that we have a woman who is pregnant, is anemic, and the anemia is not responding the routine line of management. Ideally, all pregnant women should be screened for hematological disorders, especially the hemolytic type of anemia. And common amongst them in India are thalassemia, sickle cell anemia, and the like.
They should ask in detail the history, especially the history of any blood disorders in family, even sometimes in distant cousins or parents or grandfathers or grandparents. And also if the lady has had previous pregnancies, what was the outcome, and are there any children affected by blood disorder?
Several points in the history become important. One would be what caste or community the patient belongs to. There are certain castes and communities amongst which thalassemias are very common, such as Sindhis or Punjabis. Then in areas like Vidarbha in Maharashtra, sickle cell anemia happens to be very common. So these would provide us clues as to whether this particular couple is a likely candidate to have a major baby. And also history of consanguinity. By consanguinity I mean it's marriages within the family. It is very common in India for cousins to marry each other. So if there is a history of consanguinity, there are higher chances that since both belong to a same family, the same blood tree, so they are likely to carry the particular disorder, and their progeny might be having a major problem. It is recommended that all obstetricians should screen their patients for this particular disorder by doing an HPLC test or any other suitable test, and screen their patients. If they come before marriage, well and good. If they come post marriage, maybe preconceptionally, maybe they come for treatment of infertility, that is a good opportunity to test these patients and counsel them if need be, because unless we test the mother and the father who are going to transmit this particular mistake to the baby, we won't be able to know what to look for in the baby. Now this is done by drawing a small bit of the placental tissue or drawing the fluid around the baby, which is called the amniotic fluid. So you can do what is called as a chorion Wheeler sampling, or you can do an amniocentesis. So there's a 25% chance that the baby may be well. There's a 50% chance that the baby will be like its parents. That is, it has a disorder of a mild variety and it can survive its natural lifespan. And there's a 25% chance that the baby might be having a severe type of blood disorder, like I mentioned, and the baby's life is tied to a blood bottle. Now, the greatest challenge is that patients turn up late. Most of the time, this diagnosis happens in pregnancy when in fact it should have happened prenatally, that is before conception, or even premaritally. Since many of the marriages in India are arranged marriages, it would be better for families to screen the prospective bride and groom for these disorders, but that is not usually done. One must understand that suppose if we diagnose a fetus to be having a disorder like thalassemia major, there is no treatment for this particular disorder. So the only practical management happens to be termination of pregnancy. Termination of pregnancy is permitted by law in India only up to 20 weeks of gestation, and the law is very, very strictly implemented. So it is imperative for the parents as well as the doctors to see to it that all the investigations are run through before this particular gestational age, that is 5 months complete, and they have the results, and so that they can act upon it. Now, once anybody becomes aware that he or she is a carrier of, say, thalassemia, the next step is to get your siblings screened for that particular disorder, your brothers and sisters screened for that particular disorder, their wives and husbands screened for that particular disorder, so that you prevent transmission of this particular disorder in the family and you don't land up with a kid having a major problem.
Recommendations I would divide into three. One, for obstetricians, please do hemoglobin electrophoresis by HPLC method in all pregnancies, along with your routine test at the earliest. Second is for prospective parents, please discuss openly with your obstetrician which are the tests which needs to be done, and please reveal all the history, including any major disorder in the family. And third, for larger at community, please be aware of these blood disorders like thalassemia and support doctors and parents for preventing such disorders in our community.
It should be, fortunately, the obstetrician or any doctor can prevent thalassemia, and we should work towards it and screen the families, have universal screening in place, and raise awareness about this particular condition.